same table, can, for the sake of all the postgraduates, can you tell, go back to the previous slide, and can you tell which of them have hepatomegaly and which of them have normal liver size? Ma'am,
Very
this
much
would
in order.
complete the thought process, but little out of the box. But only thing is that because you are going to palpate the abdomen next, if you can come back to these slides later on also, I'm okay. Or at this stage, if you can just tell which are the ones which are going to be expected with hepatomegaly, which are the ones which are with normal size liver or reduced.
Sir, choledochal cyst biliary atresia can present with the hepatomegaly at this age. Similarly, familial intrahepatic cholestasis, bile acid synthesis defect, allergies, genetic causes also can present with hepatomegaly at this age. And there can be no hepatomegaly in case of hereditary fructose intolerance or fatty acid oxidation defect, but other or cystic fibrosis, but other rest metabolic causes will present with the hepatomegaly.
Soma, I would like to correct you a little. So lump, choledochal cyst sometimes can present with a lump, and sometimes we may just miss that hepatomegaly. And metabolic causes, they will have a massive hepatomegaly. Mostly all the metabolics will have hepatomegaly. But most, what will they have is like tyrosinemia, where a cirrhotic picture can also come. So sir wants to know that there you may find a shrunken liver.
So this will help you to anticipate what you want to do when you go for examination.
And where will you
in
get
that context, I asked this question. Yeah. Okay, please go ahead.
What about galactosemia? Will you consider?
Soma?
Can galactosemia present with jaundice?
Yes, ma'am. It can present, but since the child was absolutely normal for the initial 3 months, so we considered the galactosemia as less likely.
You have not put in the differential. That's what I said. In the metabolic causes.
That's
Which metabolic causes are common in our country? Maybe Aditi can tell. Out of all these metabolic liver diseases, which one? Maybe in your center or. Hello?
No, probably she has disruption in the connectivity.
Okay. You go
Carry
to
on,
the next
Dr.
slide.
Soma.
Yeah. Soma, you continue.
Next.
One of the another differential we kept was perinatal infection like torch infections, because this child can also present with cholestatic jaundice with pigmented stools. But the point which was against was that there was no history of maternal fever with rash. There was no history of CNS or eye involvement, and the child was developmentally fine. There was no developmental delay, and in birth history also the child was appropriate for his gestational age.
I think Dr. Aditi has lost connection. She can rejoin. Just Soma, can you tell her? She can. She'll come. Okay. She'll come.
And for the sake of postgraduates, ma'am, I would wish that, they should not tell torch infections. It would be better if they can split it, because not all of them are similar.
Specific.
For the want of semantics, we include them. So, for example, say cytomegalovirus is unlikely. Rubella.
Yes. Sir.
Yeah. So like that, it's better
EBV.
than, telling torch as one group, It's nice to remember, but when you are mentioning, please split them, so that, you are better.
Okay, sir. Okay, sir.
This is just a small thing. Don't worry.
Dr. Soma, how are the stools? Are they bulky?
Yes, sir. The stools were bulky, sir.
You would have mentioned it.
Okay, sir.
What does it suggest? What does it suggest? Bulky, greasy stools.
It may suggest steatoria, sir.
No, not steatoria. What exactly? Functionally.
That's a fat malabsorption. It suggests fat malabsorption.
See, we as physicians, we are interested in alteration in the function or alteration in the physiology, right? Okay. Next, go to the next slide. Proceed.
So regarding examination, the child was alert, active. She was a happy child with icterus. And regarding the vital parameters, her heart rate was 112, respiratory rate was 30 per minute, saturation she was maintaining 99% under room air, and she was afebrile at the time of admission. Regarding the anthropometry parameters, Her height was 65 centimeter, which is falling between 0 to -1 standard deviation. Weight between 7.27 kg, which is falling between 0 to -1 standard deviation. Head circumference 41, which is also between 0 to -1, and mid upper arm circumference 13.5 between 15th and 50th centile. If regarding the general examination, the child was ectric, but there was no pallor.
Just a minute, just a minute.
Okay.
See the single most complaint or symptom. Just you would like to analyze it further or describe in detail.
Yes, sir.
So
No,
sir
just
wants
like
to ask Soma that you give in details why you have looked for all these things. Like you in history you told, so one parameter, one by one you
Okay.
can join.
Sir, since the child was alert active, it means
No,
the
this
child
is fine. You
not-
go to no. This is all fine, sir. Accepted.
I'm
Go
asking
to the
about
icterus.
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 Next slide,
what?
next slide.
Next slide. You describe the distribution of icterus, depth of icterus, where all you saw icterus. That's
What is
exactly
the
what I
range?
wanted to know.
sir,
That
the
would be
icterus
nice.
was involving the whole body, sir.
Whole
So
body.
but where do we look for icterus, Soma?
In the upper sclera, upper bulbar sclera.
Why
Bulbar
not?
conjunctiva.
Why not in the palpebral sclera that is
Conjunctiva.
apparent in the
In case
palpebral
of
aperture?
infants, we see in the sternum or forehead, sir.
Pardon?
No, Soma, no, you that's you were correct. Sir wants to know why is lower palpebral conjunctiva not seen for icterus?
What I'm asking is, in the palpebral, why you want to see in the upper part of the
Upper,
sclera?
why
Why
you
not
want
in
to
the
see lower?
apparent one, which is between the palpebral? See, in a grown up, it is exposed to the environment. That's why there may be some muddy color that you may mistake it for icterus. But after 6 months, maybe it may not be that issue, that much of an issue. What are the other?
No,
Suppose the icterus is mild. What other sites will give you identification at an early stage? If it is significant icterus, whole body is affected. If it is mild, which areas you specifically look for to know whether
Mucous
icterus is
membrane,
present
any-
or not?
Below the tongue, sir.
Okay.
Under
No, a question further, Beta, and
Yes.
maybe I would like to get some comments from Aditi as well. Now, is it that the scleral tissue is stained, or is it that the conjunctival layer over the sclera, which is white in background, gets stained, or is it both? You got my question, no?
Sir, I got your question.
Because this is important. Aditi,
So
you
which
can just help her out.
filament, so the elastin filaments are the one which stain the bilirubin or the biliverdin. So that is called the staining. So it is not the sclera, it is actually the conjunctiva.
Conjunctiva against the background of the white sclera that is making it yellow. Do you agree, ma'am?
Yes, sir. Yes, sir. I agree.
Good point.
If you want,
Good question.
prefer, you may. Hello.
Hello.
And on the Aditi, till she comes in on the same lines, then the upper part of the sclera is well seen than the lower part of the sclera. In general, whenever we open the eyes, the more white is seen on somebody's when we open the eyes. No, the logically.
Sir, sorry, I didn't get your question, sir.
No, the upper part of the sclera
Yes,
is
yes, sir.
more visible than the lower half of the sclera. No, in that sense, because
Right,
when
sir.
we
Right,
open
sir.
the eye.
Yes, sir. Yes,
Yeah,
sir.
therefore, the larger surface area of the conjunctiva, which is yellow against the white background of sclera, is more visible in the upper part.
Right, sir.
That's exactly, I think Dr. Ramkrishna sir was also correct when he told that the lower part may be with some other colors, but why the upper part is more yellow is also because of this.
Okay, sir. Okay,
Right.
sir.
I think Aditi has lost connection. Sorry.
Sir,
Soma.
madam,
Soma.
madam, I'm not audible.
Yeah, you are
Yes,
audible.
yes,
you
You
are
are audible.
audible.
Dr.
You're
Soma
okay.
has lost, not Dr. Aditi.
no, no.
Aditi, you can just continue till then.
Yeah,
No?
she's
She has
come.
come
She's
in.
come.
Oh, no. Yeah.
So regarding the head to toe examination, Anterior frontal was open. It was 3 into 3 centimeter and it was at level. And there was no dysmorphic faces. There were no itch mark or shiny nails. There was no xanthomas. There was no visible cataract. There was no signs of vitamin and mineral deficiencies in the form of ecchymotic patches, rickets, bitter spots, xerosis or skin dryness, and there was no palmar erythema.
Which vitamins are specifically deficient, likely,
Yes, sir.
in such presentation? Which vitamins are more, absorption of
Sir,
which vitamins is more
fat
affected?
soluble vitamins, sir. Vitamin A, D, E, K.
Right.
Go ahead.
So as per the Taiwan stool color chart, our patient has a stool color.
Please just go back. Just go back. Where do you observe for palmar erythema? Specifically, which location?
Which?
Part of the palm or the hand you examine for palmar erythema.
Sir, center of the palm will be red, sir.
No, it is all the thenar and hypothenar prominences and the fingertips.
Yes.
We can appreciate the erythema better. Right. Next. Next.
Yes, sir. So regarding the stool colors, this is a Taiwan stool color chart. Here 1, 2, 3 are all pale stools which are abnormal, and 4, 5, 6 are the normal color stools. So our patient has a color of these 4, sir.
And we generally have a protocol that we tell the patient to
Collect the stools for
collect
3
the stool sample
consecutive
in the
days, and we
days.
check it for the 3 consecutive days.
So what does this color suggest, Soma?
This is normal, ma'am.
Yes. So what does it rule out?
It rule out any kind of it rule out pale stools, ma'am.
Yes.
Yes.
So which diagnosis?
Goes in favor of it rules out basically, ma'am, structural causes of liver diseases.
Yes. Like extrabiliary atresia.
Extrahepatic biliary atresia.
Okay. Continue.
Regarding systemic examination on
Just a
abdomen.
minute.
Yes,
Which
sir.
system you are examining first?
I'm
Primary system.
examining the abdomen first.
No, there is nothing like system called abdomen. It is GIT. Okay.
GIT. Okay,
See,
sir.
you have to start from the oral cavity, and at the other end, that is the surgeons examine locally. We physicians examine systems. For respiratory system, you start with the nose. For GAT, you start with the oral cavity. Okay.
Yes,
Right.
okay. So on inspection, the abdomen was non-distended. The umbilicus was midline. The flanks were normal. There was no distended veins, scars, or sinuses noted. There was no visible pulsation or peristalsis, and the hernial orifices were normal. Regarding palpation, on superficial palpation, the abdomen was soft, non-tender, there was no guarding. And on deeper palpation, the liver was palpable 4 centimeter under the right costal margin, 3 centimeter below the Zipfi sternum. Regarding it was firm in consistency with well-defined borders with smooth surface with a span of 7.5 centimeter. Spleen was not palpable. And on percussion, shifting dullness was absent, and on auscultation, vowel sounds were heard, sir.
That's so much. Just always comment on the posterior abdomen also. Abdomen is not only on the anterior side, it's also on the posterior side. Okay? Posterior abdomen normal on inspection and on palpation, especially renal angles. May not be relevant in this case, but it shall be a system wise you go like that. Secondly, when you palpate for the liver, you say where exactly it is 4 centimeters, not under right costal margin alone. You specify further where exactly that 4 centimeters measurement.
Along the mid clavicular line.
You are expected to mention it. Okay. Why you have specifically mentioned about below Zipfi sternum? What you want to
suggest enlargement of the left lobe of liver.
So it's a good practice to comment on the enlargement of the left lobe also.
Can you tell some conditions where left lobe is enlarged?
If there is
So underlying, when there is underlying, or when the vascular, so there is a stoma.
vascular causes like Budd-Chiari left lobe can be enlarged.
And when other things more commonly we see when there is underlying cirrhosis developing. And
Compensatory
congenital and when we keep seeing those children with congenital hepatic fibrosis, soma, where we keep having
left.
left
lobe.
hands.
Yes.
So all cirrhosis, to summarize, all congenital hepatic fibrosis and
Any vascular thrombosis in the hepatic veins like Budd-Chiari.
No, basically what postgraduate should understand is that when there is a pathology which is unique to liver, both lobes enlarge, but the being volume of the right lobe is more than that of the left lobe, right lobe is likely to enlarge more than the left lobe. But on the contrary, if there is persistence injury and if there is a cirrhosis, there is shrinking, and the shrinking is more volume wise
right lobe.
visible on the right than the left, and therefore you may have contrary when you have got a left lobe palpable in contrast to right. It could be both possible that the left is enlarged or the right is shrinking. So you have to make some kind of analysis.
If the surface is not smooth, what it can be otherwise?
It suggests cirrhosis if it is
No,
nodular.
nodular is suggestive of not
Cirrhosis.
cirrhosis. No, you specify further. It's not simply cirrhosis. The nodules are areas of
Proliferation, sir.
regeneration. We call it as
Regeneration.
regeneration rather than
Yes.
proliferation. Okay, it's not cirrhosis. It's the nodules suggest there are areas of regeneration. Coming to percussion, never say shifting dullness absent. You say the abdomen is resonant all over in all areas.
Okay.
You tell Dr. Subramanian is telling, be positive. Huh? Has complimented you.
Yeah,
Say,
because the shifting dullness is only going to roll out moderate amount of fluid. It's not going to roll out small amount of fluids.
Okay.
and on auscultation, bowel sounds are normally present. Okay. In intestinal obstruction also bowel sounds are present. In paralytic ileus also they may be present. So they are normal. Okay, that you mentioned. Where else you would like to auscultate in this child? Apart from bowel sounds.
Yes,
Do you
sir.
want to keep the stethoscope? Sir wants to know whether you want to put a stethoscope somewhere else also in while doing
Or we can look for hepatic buoy, sir.
Yes.
Right? You make a mention of it, right?
Okay, sir.
That gives you
Any
extra
murmur you
points and
hear?
extra gold medal.
Can you-
right?
Any murmur which you can hear?
radiation to
We can hear continuous murmur if there are any vascular stenosis.
Vascular stenosis?
Murmur,
not
murmur,
stenosis.
I couldn't
Not vascular.
understand. Murmur.
Ma'am wants to ask any murmur in abdomen. So it
Abdomen.
either could be radiated or it could be AV malformations, not stenosis.
There is some named murmur, which is very famous. It's there in all hepatology books. Aditi can tell.
Sorry, madam, I can't.
Cruvelier,
Oh,
Baumgarten.
Krugel.
Sarah
Yeah.
madam is by experience gastroenterologist.
This
Okay.
murmur which you hear in cirrhosis. Okay.
Dr. Sama, you always tell a point like that, no other mass is palpable. It's not that only liver and spleen are the ones which get enlarged. It may be other viscera, it can be lymph node enlargement. So make it a practice to say, commented about liver, then spleen, no other mass is palpable, right? Okay.
And
we'll go.
and preferably you can always comment and tell that gallbladder is not palpable. I don't know how much it makes sense, but at least we don't expect a gallbladder to be palpable, but at least you can make a mention.
In this case, also
Especially
about
if
radial
in the
slope
hospital.
also. Radial slope also you may comment.
You can comment. There's nothing wrong, but you should be able to defend in exam, Mama. I cannot come to your defense. Okay.
Yes, proceed.
Regarding the other system, regarding respiratory system, air entry was equal bilaterally with normal bronchovesicular breath sounds, and there was no added sounds. On cardiovascular examination, S1, S2 was normal, no murmur heard. And on CNS examination, the child was alert, active, playful, turning head to sounds, and tone and reflexes were normal on examination.
That Soma,
Yes, sir.
suppose I find the child to be a little irritable, a little lethargic.
Yes, sir.
What does it suggest? Some behavioral
Sir,
changes are also there of late.
yes, sir. It can be a sign of early hepatic encephalopathy, sir.
Good, good.
Can it be
Apart
some
from
metabolic
that,
cause?
apart
It
from
can be
that,
metabolic. Can it be
so one of the
Yes,
hyperglycemia?
sir. It can be metabolic. Yes, sir.
So, sir,
Please remember, don't forget. And can it be hepatorenal with some electrolyte abnormalities?
Yes, sir. Yes.
Please rule out metabolic before you get into other things.
Right.
So
Okay.
on jaundice child with irritability, we have to rule out any ICH, which can be very
Yes,
catastrophic
exactly.
because of cardiopathy. Then definitely HE, which is evolving. Third, rightly sets any
Metabolic
infection,
electrolytes.
metabolic. So per se, the metabolic crisis can cause delayed mentation.
Which sign is the earliest to appear when there is early hepatic encephalopathy, sign wise?
Sir, first there will be alteration in the sleep-wake cycle, sir.
Okay, the symptoms
be
and
the
sign.
first
I'm trying
manifestation.
specific sign,
Fine.
which you elicit. Okay.
Sir, in generally in older children, we elicit asterisks.
Okay, that is not early. The one
Yes,
of not in this baby.
And other the tender knee jerk can be exaggerated. One of the earliest examination findings, sir. It is seen in encephalopathy stage 3, sir.
It is the plantar extensor that is the earliest, not in this baby. This baby is infant. Beyond 1.5 years is the upgoing plantar as the one of the earliest sign. Okay, carry on. Proceed. Proceed.
So after history and examination, I want to further summarize my points. So this is a 6-month-old infant with cholestasis, with pigmented stools, with oily stools since 3 months. She was born out of 3rd-degree consanguineous marriage. On examination, there was moderate firm hepatomegaly without splenomegaly, no pruritus or pains, with normal growth and development, without features of decompensation like ascites or bleed or fat soluble vitamin deficiencies in the form of vitamin K dependent bleeds, rickets or corneal xerosis, no dysmorphism or extrahepatic manifestation in the form of cardiac or chest or neurological issues. So
Yes,
after
but one second, stay back on the previous slide. I've got a question to ask. Now, you said decompensation. Now, I wanted to ask a question to you. How did you conclude that the jaundice is not a feature of decompensation, but a symptom and a sign of the disease itself? I think you understood my question better.
yes, sir.
How will you define that it is not decompensation but part of the sign or symptom?
Because sir, there was other signs were not there, like ascites or bleeding, which we
So
generally
they
see in
are
case of.
related to further decompensation. Is jaundice also a sign of decompensation?
I want to ask whether we will consider jaundice as a part of decompensation.
Decompensation.
This is an important point because that will take you through the process.
Sir,
See,
if there is a falling bilirubin, or if there is a fall in transaminases level, it is a feature of
No. You try to tell
at
clinically.
clinical examination itself.
Clinical only.
See, I will ask.
not labs.
I will make your question very clear to you. So, how do you know that the hepatomegaly was not existing prior to the symptoms that were present? For example, the child had 4 centimeter liver. It could have been 1 centimeter, 2 centimeter, then 3 centimeter, 4 centimeter. It could have been a progressive hepatomegaly, and then jaundice appeared at that time. Mother got worried. Now, how do you know? How can you get into this like onset of the disease process versus the mother becoming aware of the disease?
Someone wants to ask. Yeah, you answer.
Sir, since it is progressive,
Progression
Agreed.
would show what you have written
Okay,
without.
Dr. Adti will enlighten.
Total
Dr. Adti will
hypertension.
enlighten. Right.
So Soma, you have written it so well. So you have tried to elicit that there is a hepatomegaly, but that
Yes,
child
sir.
is not having the stigmatas of CLD. She's not going into features of portal hypertension. So without any features of portal hypertension and without any features of other features of decompensation, that bilirubin doesn't
So
look like
isolated jaundice may not be a feature of decompensation, absence of other decompensation features,
Mhm.
isn't it?
Okay, sir. After a history and clinical examination, these are the difference.
I think we had changed our first possibility after history and examination was the next slide.
Yes.
Yeah.
So after history and clinical examinations, we have kept the possibilities as genetic as one of our most common possibility in the form of familial intrahepatic cholestasis, bile acid synthesis defect or allergies. The point in favor was that the child was having cholestatic jaundice. There was a history of consanguinity. She was passing pigmented and greasy stools, and there was presence of hepatomegaly. But the thing that was against was there was no pruritus and there was no other extra hepatic manifestation. Regarding metabolic, these were the differentials we kept, and the points in favor was that the child was having cholestatic jaundice with pigmented stools and third degree consanguinity. But since the child was not sick looking, she was well thriving. There was no history of seizures, recurrent vomiting, feed intolerance, or aversion to food lethargy. So these all were going against metabolic causes. So after that, we also kept the possibility of structure causes like choledochal cyst or stones. But since there was no lump or abdominal distension on examination, there was no history of pale stools, no splenomegaly. Because generally this child present with splenomegaly at 6 months of age. So as there was no splenomegaly, so these were a few points which was going against choledochal cyst. And one though unlikely, but still we kept biliary atresia as one of the possibilities. Because it is the most common cause, and the thing which was ruling out biliary atresia was that the child was totally normal for the initial 3 months. There was no history of pale stools, and there was no splenomegaly, because this biliary atresia child at 6 months generally they present with splenomegaly and features of portal hypertension.
I think, Soma, after it's okay, you consider a broader diagnosis after history. Now you have the history, you have the examination. Can you narrow down your differential? I think we should be able to narrow down a differential. Would you still consider biliary atresia now after examining the child? And you've so that's what I'm asking. At the end of history, you must have a larger diagnosis, but now you have examined the child, you know the positive findings, you know the negative findings also. So would you like to narrow down and put it in the order that what really are you considering as
1, 2, 3.
1, 2, 3, the most probable diagnosis in this child?
Sir, ma'am, first we will keep genetic as the most common, then metabolic, but we will still keep biliary atresia as our differentials.
No, that's what I'm asking.
So,
I don't know.
Soma, we had told that after examination, our DD would be predominantly genetic or a metabolic.
That's yes, ma'am.
Structural, we had said choledochal cyst could still be a possibility, but the chances of biliary atresia is highly unlikely.
Unlikely.
Highly unlikely. So you will almost not consider. So
practically not considered.
Not considered, because a 6-month-old child without any spleen. So we had kept that bracket unlikely.
Yes.
This method,
yeah. In the genetic, I just want to ask, in the genetic, when do you get pruritus and progressive familial intrahepatic cholestasis? What age?
So when does the receptors develop, Soma, we want to know.
3 to at 3 to 6 months they can develop with excessive irritability and itching of ears.
After 3 months, 3 to 4 months?
So 4 months is when the receptors start evolving. So it may take up to 6 months, but how do you elicit pruritus in small children? How do they start beginning? You should.
Yes, that's important.
There can be scratch marks over behind the ears or on abdomen, and they can be irritable, ma'am.
These are predominant irritability, rubbing of
Yes,
eyes, and tugging at ears rather than a frank pruritus.
Mm.
So even in the genetic, I would like to, are you considering Alagille syndrome here? Is there any dysmorphic facies, cardiac anomaly?
That can be
That's what I'm saying.
excluded.
So after the examination, this slide was okay for your history. But after examination, I want you to be more specific, little more specific. Like biliary atresia, it's not, it's out. Alagille
Alagille
syndrome, are you really
out.
considering in this child? There is
Ma'am,
no
sometime
dysmorphic facies, I don't think any cardiac anomalies.
ma'am, sometime allergies may not have developed dysmorphic faces within the infancy. It can
Okay.
uh,
Okay, so you're still considering. Okay.
yes.
Okay.
Yes, ma'am.
What about the metabolic like tyrosinemia? You think by 6 months tyrosinemia, there is no coagulop, I suppose there is no bleeding, no coagulopathy.
So,
I just want to know what's your take on that.
So in metabolic diseases, ma'am, we have to keep definitely more important would be other causes like fatty acid oxidation defects or a citrin deficiency.
Yes.
Typical book teaching is that tyrosinemia will bleed or they will present with coagulopathy. But a lot of times child will present with hepatomegaly, slow failure to thrive, and they may not manifest coagulopathy till we elicit, till we do the lab test and we find INR as deranged. And they may come only with florid rickets, though there was no rickets in this child.
Okay. Even fatty acid oxidation defect and fructose, we would have expected some hypoglycemia and seizures, lethargy. There's no such history, I suppose, in this patient.
Yes, ma'am. On history wise, and there was no seizures and no history of lethargy.
And for some time, the Aditi brought in the discussion of congenital hepatic fibrosis. So, is it possible or not possible? Basically, what happens in congenital hepatic fibrosis? There is histopathologically, there is pericellular fibrosis, isn't it? And
Yes,
therefore,
sir.
there is going to be massive hepatomegaly, and there will be
Yes.
more features. Features of congenital hepatic fibrosis are same like constrictive pericarditis. You know, you are going to get ascites, you are going to get some manifestations. And if you do ultrasound, you may find renal cysts, but they
Yes,
may
sir.
come in second decade of life. Not initially, they will have hepatic presentations, and in second decade, you may get renal cysts, isn't it? And they may
Yes.
die of, madam, and if you agree with me, they may die of renal disease than hepatic disease many a times.
Right. So I want to tell that about the CHF, there is two spectrums. The first age is at neonatal, when they predominantly present with a renal failure rather than a jaundice. They would have a hepatomegaly in a child who has come with a renal failure, and then they find cysts. And incidentally, they find a large firm liver, and then they find CHF. Predominantly don't present with jaundice at 1 month.
Jaundice is not a manifestation. That's the point. Which,
Yes, there is an important point. Right.
Again, from this CHF.
What about
what about alpha-1 antitrypsin deficiency?
So, sir, when all Western guidelines, this is one of the most common DDs if we have ruled out biliary atresia. But in India, there is dearth of knowledge as per se. But one AIM study, they have said that there is very low incidence. Not even 1% of the all cholestasis population is alpha-1 antitrypsin.
So Aditi, all the 36 pages which you have read is a waste now. Alpha-1 antitrypsin deficiency. Okay, thank you.
I want to know, ask Soma, what about cystic fibrosis? Will you consider in this child?
Ma'am, unlikely because there was no history of recurrent chest infections in the past, ma'am. And there was child was well thriving, no failure to thrive was there.
Okay.
How would you relate the greasy stools, bulky stools with icterus? When they are coexisting, what are the probable clinical scenarios? Clinical conditions.
Yes, sir.
Sir wants to ask Soma, is there any connection between jaundice and greasy stools?
See, he asked this question after the question of cystic fibrosis. Therefore, he has got a link from that. That's the hint, no? When examiners ask the question, you should remember what was the last point of discussion.
So why will a stool be greasy? What are the deficiencies we have when stools become greasy? Deficiency of?
Deficiency of bile acids.
Right.
So bile acids. Right. And the other thing, as I said, cystic fibrosis per se, because of the pancreatic hypoplasia.
Right.
Yeah.
So
Yes.
this was our last possibility of perinatal infections but it was less likely because there was no history of fever with rash, no CNS or eye involvement, and the child was developmentally normal.
But Soma, as Dr. Sarah madam was telling, you shall not project the same slides again after physical examination. Try to narrow down to 1, 2, 3, 4. That is better.
Yes, sir.
Okay. At least you would have taken up 50% of the diagnosis which are mentioned in these tables after physical examination. Right?
Madam, being examiners, I wanted to ask Ramakrishna sir and Sarah madam, if a student does complete the examination without fundus examination, will you give them marks or no marks? But I think here actually for considerations of CME and others, we really need ophthalmologist, not a pediatric student. So therefore, there should be some margin for if somebody doesn't examine the fundus.
But
Ramakrishna sir and madam, your remarks?
Yes, sir. She should have mentioned, but I'm sure.
At least, okay, I will get an ophthalmoscopy for completion of examination from a experienced ophthalmologist. That they can confess.
Okay, sir.
Right.
Because it's a part of examination rather than an investigation,
Yes, very much.
And fundus is a examination of eyes is a very good clue for many metabolic diseases as well. So never
Also
miss.
perinatal infections.
So well taken, sir. This is actually very relevant in this case, and we got a fundus done, and we put it in the investigation. Probably this was wrong.
No, that is part of clinical examination.
Aditi, I'm very happy that you are telling that it should be part of examination than in investigation.
Right. Part of examination, clinical examination. Right. We'll go ahead. Dr. Soma.
Yes, sir.
Fast.
Soma, go.
As per this diagram, we can as per this flow chart, our child is a case of neonatal cholestasis. The child was well thriving, the child is not sick, and he was passing pigmented stool. So we did our investigations as per these guidelines, and here we did fasting ultrasounds. We went for metabolic test. We subsequently we also planned for liver biopsy. So regarding the investigations, the child has a low hemoglobin, which was 8.9. Her TLC counts were elevated, 24,000. Neutrophilic neutrophil was 22.8%, lymphocyte was 68.9%, and eosinophil was 4.6%. The platelet counts were 5.56 lakhs. MCV was 75.6, MCS 22.2, and on peripheral smear there was predominantly microcytic hypochromic cells, and corrected retic count was 1.6%. So as per this investigation, the child is mainly having microcytic hypochromic anemia, and since the retic count is normal, it rules out a hemolytic cause of jaundice.
Was there any NRBCs? Any NRBCs?
No, ma'am, there was no nucleated RBCs.
Cause for anemia?
Cause for anemia, we kept it can be
Nutritional, iron
So
deficiency.
MCV was low.
Iron deficiency, we thought.
Microcytic hypochromic.
Microcytic hypochromic, so we thought of iron deficiencies are nutritional.
Along with anemia of chronic disease, which cannot be ruled because he is having
anemia of chronic disease, right?
Yes.
What do you look for in the PS in liver disease?
In liver disease, we can the MCV can be high. We can get macrocytic cells.
Targets, Soma.
Yeah.
Target cells, we see xanthocytes, macrocytes.
Macrocytes, yes.
Okay.
So regarding the LFT parameters, her bilirubin was elevated 22.7 with conjugated bilirubin fraction 10.8. There was presence of transaminitis, SGOT 392, SGPT 342. ALP was elevated 626. Though the ALP was elevated, the GGT was normal. It was 28.7. The total protein was 6.4. Albumin was 3.5, which signifies the normal synthetic function of the liver. The globulin was 2.9, and there was no AG reversal. Regarding
just 1 minute. Go back. Go back. Just go back. Dr. Aditi, would you like to comment on GGT being normal when other transaminases have risen?
So yes, sir, definitely. So as I told Soma, so we had to elaborate that there was a high bilirubin and there was a mixed mixed component. So 22 is high with a conjugated 10, with an unconjugated being almost 12. So it is
12.
showing there is a both hepatocellular and a
Yes.
excretory dysfunction. Then we want to
Yes.
elaborate on SGOT and SGPT. So PT is more specific for liver, is it 342, and OT is almost equal to PT. So again, if the OT would have been more, we would have thought there is some underlying hemolysis or some muscle involvement, which is not there. It's a predominant hepatocellular involvement. Now the third, the cholestatic parameters. So as Sir said, ALP and GGT. So ALP 626 is very high with a normal GGT, which is
Normal
again a
GGT.
marker of, which is normal. So why this discrepancy? Either there is a ALP is high because of the other source, like this is a rickets and there is a growing bone.
Exactly,
And
exactly.
it's
Right,
high
ma'am.
and GGT is normal, or is it some other liver diseases? So there are three conditions where there could be high ALP with a normal GGT in a cholestatic child, relevant in our case, not in elderly. So those would be or
Bile
acid
synthesis defect or junctional protein defect.
and arthrogryposis syndromes.
Yes.
Right.
So what are the two synthetic parameters you wanted to say? One was, as Sir had
One was
already elaborated, early
albumin
was an
and
I.
albumin and other was INR.
Yeah.
Regarding the coaglogram, her PT was elevated 15.8, APTT was 38.8, borderline elevated, and INR was elevated 1.48. So we have given vitamin K for 3 days. After giving vitamin K for 3 days, her INR improved to 1.3. So it was vitamin K responsive. And regarding the KFT parameters, the parameters were within normal range. Regarding proceeding with the radiological investigation, we did the ultrasound abdomen. In fasting ultrasound abdomen showed a contracted GB of 18 mm in length with indistinct mucosa. No triangular sign was elicited, and the pre-postprandial volume change was suboptimal. There was no polydocal cyst, no splenomegaly, no renal cyst. KUB was normal. There was no ascites. So as per a radiologist, it was a hypoplastic gallbladder. So it was difficult to rule out biliary atresia.
Based on
Oh,
this, Soma,
no,
what
just-
did we decide?
No, before that, for your
Yes.
friends and colleagues, you tell what is triangular cord sign.
Sir, triangular cord sign, basically triangular cord sign is a echogenicity noted in ultrasound above the portal vein, which is the remnant of the extrahepatic bile duct, sir. It appears as a echogenic thing above the portal vein.
Right portal vein,
Ultrasound.
EARPV.
Significance?
Dr.
Significance?
Dr. Aditi, for the postgraduates, I would like you to just mention
Summarize.
features, the importance of ultrasound examination in cholestasis. What are the things we are supposed to be looking for?
So,
US.
sir, okay, ma'am. Sure, ma'am. I'll try to summarize. So, as per the guidelines, if there is a sick child, if it's a stable child, and we are thinking of persistent pale stools, we have to look for biliary atresia. But in a child we are having a well child with an intermittent pale stools, we are thinking of choledochal cyst. First ultrasound, we look for any cyst. If it is a large cyst involving a bile duct, or the bile duct is more than 4 mm, it is suggesting a biliary dilatation. Second, whether there is a features of biliary atresia. To begin with, we can have a ghost triad. So what is a ghost triad? The GB size is less than 17 mm or 19 mm. There are two studies, 17 to 19 mm. Less than that is considered as a small GB. This should be done in a fasting state, because we assume that in a fasting state, the GB gallbladder is distended. So any contracted GB could be post-feeding status also. So all child should be fasted for at least 4 hours before undergoing an ultrasound. They should have a length of at least 18 mm. Now the ghost triad, the mucosa is irregular, the GB looks contracted, and there is irregular lining suggesting atretic GB. Even we can have absence of GB. So a lot of ultrasounds will show there is absence of GB. Fourth thing is there is presence of triangular cord sign, or that is echogenicity anterior to the right portal vein. So this is the remnant of the bile duct, which becomes more echogenic and seen on the right portal vein. And then the fourth thing is the after doing fasting, we tell the child to feed and we repeat the ultrasound to see the postprandial contractility. So based on these parameters, we decide whether the child is having all the parameters which are suggestive, or there are one feature which is suggestive, or there are multiple features. Apart from that, there are also Doppler studies. So they see subcapsular increased vascularity. They also see presence of increased hepatic artery resistance. So these are second features. And apart from that, presence of splenomegaly will confirm there is ongoing portal hypertension suggesting biliary atresia.
Ma'am, I have got a couple of questions. Sorry, you continue, then I will ask the question.
No, sir, it's almost done. The most important fact was
Yeah,
that it
I
has
wanted to
be
know
done
from you or from the student exactly what is the sensitivity, specificity, positive or negative predictive value of finding a gallbladder in an USG in a suspect case of cholangiopathy. Because moment you find gallbladder, it rules out or rule in some disease, and how significant it is. Number one. Number two, how often a clinician should ask for hepatic Doppler along with USG, or just an ultrasound and then SOS Doppler? Please, because we are writing investigations, we wanted to have that clarity.
So for the first case, in case of ultrasound, the sensitivity is not very good. It is between 60 to 70%, even after multiple systematic reviews. So it cannot be solely relied upon. And it is just
If I'm a practitioner, should I take two sonology from two different centers?
Sir, I think it should be more on a sonologist who is more experienced in seeing neonatal livers.
Okay, done. Point taken. Next.
Second question regarding Doppler. So in neonatal cholestasis spectrum, maybe a Doppler is not very important in finding because we may find a GB. But in all CLD cases and all children we are having portal hypertension, there a Doppler is a must, because presence of portal vein thrombosis and presence of hepatic vein thrombosis is an important etiology.
Should we suppose this is a cholangiopathy going on for a chronic liver disease like cirrhosis? So should we ask for Doppler after splenomegaly appears or even much before splenomegaly appears? This is my question. I think you are getting my point.
Right, sir. But biliary atresia is a progressive disease. Asking for a portal vein size at the time of diagnosis itself, it may not be a problem. We can ask there that itself also. Especially if at 6 months, if a child had presented with a biliary atresia, probably it's a late presentation. Portal vein diameter should be known.
Okay, thank you.
Yes, Karian. Time is.
So proceeding further, we also investigated for underlying sepsis, in which CRP was done, which was within normal limit. Procal was negative. There was no blood growth noted in blood and urine culture. Regarding CMV status, CMV IgM was negative. We also sent the CMV urine PCR. It was a positive. And regarding the thyroid function test, the thyroid function test was absolutely normal. We have done the LRGD workup, in which we have done echo. There was no features of peripheral pulmonary stenosis in echo. X-ray spine showed no features of butterfly vertebra, but there was the total cholesterol was elevated. It was 213, HDL 24, LDL 109, and the other thing which was in favor of LRGD was the GGT was not high, and there was no evident dysmorphism.
GGT not high is not supporting allergies, and eye examination was done where there was
no feature of posterior embryotoxin.
But we found chorioretinitis in this child.
Okay.
Yes. Regarding the metabolic screening at admission, the child was having hypoglycemia. His fasting blood sugar was 38 mg per dl. So then we have taken one critical sample. In critical sample, urine ketones were negative. The lactates were high, 4.6. The pH was normal, 7.35, and bicarb was 33. We have done non-glucose reducing substances, which was negative in urine, and the CPK was done which was normal. Ammonia, we didn't send ammonia levels, and AFP levels was done, which was borderline elevated 600. And regarding lipid profile, it was deranged. Total cholesterol was 213, HDL 24, and LDL 109. So considering all this, we kept metabolic liver disease as our possibility, since despite having hypoglycemia, the urine ketones were negative, so we considered fatty acid oxidation defect as our possibility. Since the lactate levels were high, we also considered a mitochondrial liver disease, and we also suspected hereditary fructose intolerance in view of hypoglycemia. And further, then we sent the TMS levels. TMS. Regarding if I conclude the course of treatment, the child initially presented with cholestasis with coagulopathy and steatoria. So we supplemented with fat soluble vitamins. We added UDCA at 20 mg per kg per day. The feeds were made more frequent with complementary feeds. We excluded any kind of sugar or honey, and MCT oil was also added. The child developed hypoglycemia with high initial lactate levels, for which we have started on a GIR at 4 to 6 mg per kg per minute. We ensured frequent feeds, and sugar was regularly monitored. As we have kept the possibility of metabolic liver disease, we sent the TMS, and mitochondrial regimen was added. And regarding CMV PCR positivity, since it was CMV PCR was positive in urine, we added valganciclovir. And since the sonography was very doubtful, showing hypoplastic GP, we planned for liver biopsy. And to rule out the metabolic causes as well as the genetic causes, we planned for clinical exome with mitochondrial panel. Regarding, okay, can I proceed?
Yes.
Regarding the histopathology findings, there was diffuse hepatocellular lobular swellings. There was presence of cholestasis, which is due to accumulation of bile acids and bile pigments within the hepatocytes. There was giant cell transformation. There was micro and microvesicular steatosis. Spotty necrosis and scattered hepatocytes was also noted. Trichome stain showed patchy lobular collagenation, but there was no features of fibrosis, which is ruling out biliary atresia. CK7 was positive, which is a marker of ductular proliferation. There was no stainable iron, ruling out hereditary hemochromatosis, and no stainable copper. And there was no ductopenia, which is ruling out bile duct paucity syndrome. Hence, from the histological findings, we can very easily exclude biliary atresia, and we kept the possibility of metabolic liver disease. We sent TMS. In TMS, there was elevated free carnitine. It was not typically suggestive of fatty acid oxidation defect, and other rest amino acidogram and acyl carnitine profile was normal. So we thought of sending clinical exome. So if I summarize, this is a case of cholestasis of infancy with pigmented stools with steatoria, with onset at 3 months of age, without pruritus or failure to thrive, with hepatomegaly, with low GGT, vitamin K corrected coagulopathy, dyslipidemia, with episodes of hypoglycemia and increased lactate at admission, with the CMV PCR positivity in urine, and without any features of sepsis. Hence, we send the clinical exome, which we get in our follow-up with the reports came, and it came out to be there was a mutation in HS D3B7 mutation, which is a homozygous mutation, and it was correlating with congenital bile acid synthesis defect 1. And regarding the mitochondrial panel, no significant mutation was noted in the mitochondrial gene. So as the child was having a mutation suggestive of bile acid synthesis defect, so in follow-up we have also sent serum bile acid levels, because in initial workup we haven't sent it. So serum bile acid levels was sent after stopping the UDCA for 1 week, and it came out to be low. It was less than a 10 unit mole per liter. So we kept the final diagnosis as bile acid synthesis defect, and for further treatment, we started the child on oral folic acid at 10 mg per kg per day. So regarding disorders of bile acid synthesis and metabolism, it is a rare metabolic disorders which is due to primary defect in the production of bile acids and are a part of class of progressive liver disease. Clinically, the bile acid synthesis defects generally manifest with intrahepatic cholestasis and malabsorption of fat and fat soluble vitamins, as we have seen in our case. And most patients have mutation in HSD3B7 and AKR1D1 genes. So I want to conclude my whole presentation. So this is a case of inborn error of bile acid synthesis, which is a rare genetic disorder accounting for only 1 to 2% of cholestasis. Now we should suspect it in any case of in any infant who is presenting with the cholestasis with a normal GGT and in absence of pruritus as seen in our case. So we have to screen with serum bile acid levels, and for confirmation we can send clinical exome or fast atom bombardment mass spectrophotometry. And oral therapy is with folic acid and the condition is well treatable. Prognosis is good if we treat early before onset of cirrhosis.